don't just talk health, we do health. SMS MedShield to 33023 or talk to your broker to get your kind of care.
Pregnancy is for some a joyful journey coupled with lots of excitement. For a new mom, it's a journey to a completely unknown world. But for some, it may be a rocky ride, especially in the beginning and right at the end. So February 8th to 14th is Pregnancy Awareness Week. So today we focus on this journey, pregnancy. And to help us navigate through this journey is a guest panel comprised of a specialist obstetrician and gynecologist, the Deputy Director General HIV/AIDS, TB, Maternal and Women's Health from the National Department of Health, and a midwife from Maxeke Hospital. So if you want to be part of this show by, asking us some questions or simply sharing your views with us, the number to call is Johannesburg 714-6841, 6842 or 6843. You can also tweet us at SABC Health Talk or simply just interact with us on our Facebook page, SABC Health Talk. So sit back, relax and learn from this exciting show ahead. I'm Dr. Thandi and this is Health Talk.
The last few days of pregnancy can be anxious moments for both parents.
I was worried when I got here because I got some pains. I thought maybe there might be something wrong, but it turns out it's because of the weight of the baby as he's growing and all that, so everything is okay.
A usual pregnancy takes 40 weeks from the first day of your last menstrual period until the baby is delivered. The journey is divided into 3 stages: first, second, and third trimester. Pregnancy is a normal state and it's important to receive adequate pregnancy care on the earliest stage to ensure that both the mother and unborn baby are healthy. Even so, your body will undergo significant changes from the way it usually functions.
It's a healthy journey, never had complications, and the only thing that I never experienced before was the nauseas. But mine, with other people, it will be the morning sickness. But with me, it was in the evening. Like my evenings were awful. And you can imagine, because that's the time where you have to do the cooking and all that. Everyone, even in the neighborhood, you'll be smelling food. So, yeah, my first trimester was very not nice because of my evening sicknesses.
The physical and emotional aspects of pregnancy differ for many women. It is important to get the appropriate nutrients and energy needed to keep you and your baby healthy.
On a daily basis, I ensure that at least I have at least 2 different types of fruits, and water is very essential. I make sure that I finish my 1.5 liter a day, if not more. And then exercising, I just do walks.
A partner's support during this busy time is significant for the mom and baby. A woman who gets support from her partner during and after pregnancy may feel happier and less stressed. This will lower stress in mothers and may help infants too.
It's a matter of you making sure that, like, when she's sick, and then you are there for her, and then you do the cooking and the morning sickness, and it's quite challenging though. And then even like, you know, most us men, you have that thing of going out and all this, so you have to cut some of the things just to make sure that the support is there, and whenever she needs you, you are within the reach.
If you know you are pregnant or think you might be, visit your healthcare provider. Whether or not this is your first pregnancy, early care will help keep you and your baby healthy.
So let's learn more about this journey. And with us in our Johannesburg studio is a very special guest, Dr. Thandi Mtsi, who's a specialist obstetrician and gynecologist based here in Johannesburg, and she's got loads and loads of experience. I mean, she's been a specialist obstetrician and gynecologist for many, many years. Welcome to Health Talk once again, Dr. Mtsi.
Thank you so much, Dr. Mtsi.
All right, let's perhaps start at the beginning of this journey. I mean, this journey starts with, I suppose, fusion of a male sperm and an egg, and just tell us what happens.
I'm not going to go into the whole of ovulation stuff like that.
Yeah.
The egg and the sperm combine and they form something, a
Right.
fusion.
Right.
And that sits in the tube for a while, and then it goes. You must remember that the sperm has to travel through the uterus to the tube to go and wait there for the egg.
Right.
The egg comes from the ovary.
Right.
And it sits there, and that the timing is also quite important, which nature does easily, but sometimes we have to assist.
Yeah.
So it occurs at around the time. If it occurs at around the time of ovulation,
Right.
we can get both egg and sperm getting together. So they sit there for a few days. I mean, the combination sits there for a few days, then it comes back down into the womb, and then that becomes a baby. Implantation occurs.
Yeah.
And that's quite important actually for people to remember, because it's the early determination of whether you are having a proper, normal, healthy pregnancy or not.
Yeah.
That's the first step.
Which
when
is-
that pregnancy goes from the tube
Yeah.
into the womb, then starts other problems.
Correct. And I don't want us to go back into a whole lot of other issues, but clearly it's important what you mentioned now, that what is regarded as normal is when this thing goes down right into the womb and grows into a baby. But things
Yes.
can go wrong. Sometimes
Exactly.
it can get stuck in the tube. Tell us about that.
Exactly. This is why I mentioned it and emphasized on it, because we see a whole lot of patients with ectopic pregnancy.
Right.
That is when the pregnancy is growing outside the womb. It can be on that tube, it can be stuck there, or it can be outside in the abdomen as well.
Mm-hmm.
As long as it's not inside, it's called ectopic.
Right. Okay. Now we're back into the normal one now.
Yeah.
Okay. There can either be one baby or two babies. Tell us about that.
It can either be one or two or even more, or
Right.
even three, or even no baby.
Yeah.
That we must also remember.
Right.
That there is a stage where there can be fertilization. The fertilized egg goes into the womb and it doesn't divide, it doesn't form a baby.
Right.
And sometimes it starts by being what we call a blighted ovum.
Right.
Where patients don't usually understand. They say, but I'm pregnant, I've got pregnancy symptoms, but you are saying there's no baby.
Yeah.
So that can happen, or the baby can develop, and after a few weeks or a few days,
Yeah.
the heartbeat goes and it becomes a missed abortion.
Yeah.
And then you can, now the third stage is that of a fully formed baby, whether it's 1, 2, or 3.
Okay,
And
let's go
that's
into that
the
in
babies.
a bit more detail now. Or firstly, in terms of when does somebody know that she's pregnant?
It depends on how vigilant or sensitive people are. Within a few weeks, there should be, in fact, the first port of call is usually the fact that you've missed your period
Right.
as a woman.
Right.
So as soon as the patient misses the period, she knows, she suspects that she's pregnant.
Right.
And during that time, there's very sensitive tests that can be done now,
Yeah.
where you can actually pick up that she's pregnant. You may not be able to tell her how much or how far, but you can tell her that she's pregnant.
Right.
And then the symptoms start. There are people whose symptoms do not are not as strong as indicating as all that.
Yeah.
I actually was called by one of my daughters a few I think last year or so, to come and watch a show from the US which says I didn't know I was pregnant.
Right.
Where people are coming at 36 weeks.
It's a very interesting one because it does happen.
Highly unusual.
Yeah.
Highly unusual because something has to change. Okay, there are people who bleed, but you see the problem with those kinds of people are not vigilant enough.
Right, right.
The period is never normal when you are pregnant.
Right.
You may bleed, but it may be less, or there may be something happening with the period.
Right.
And there may be some unexplained weight gain for some people. Okay, the bigger ones are very difficult to determine, but the pregnancy has, and the movement is what amazes me.
Yeah.
A baby at 20 weeks starts moving. The movements start being felt by the person who's having a first pregnancy.
Right.
Second pregnancy, by 16 weeks, you can feel that there's something going on in your tummy. It may not be an aggressive kind of movement, but there will be something going on. Every now and then.
You're actually going into what I was going to ask next, to say, all right, what can a pregnant woman, expect to experience throughout the journey? Because earlier on we said it's divided into 3 trimesters.
Yes.
So what are the typical things to expect in each of the trimesters?
Yeah, women experience pregnancy relatively differently. You mentioned it very nicely when you said there was emotional elements and psychological elements and also physiological and medical elements.
Right.
But the most common thing is, as I said at the beginning, is missing a period.
Right.
That's the first thing. The second one, which is very common, more than 60% of our patients will experience the nausea. And that's the worst, and it tells you that some people may even have dizzy spells because now they are not eating properly, and they become hypoglycemic and all that. So those are the very early symptoms, especially the nausea, especially just feeling lightheaded. Some people describe it as feeling very lightheaded. Something is wrong, but not wrong. But, every time I wake up in the morning, there's something going on. And because the movement thing is so much later. It's, as I said, for a second pregnancy from 16 weeks onwards, and for an early pregnancy it could be around 20 weeks. So those are some of the symptoms. There may be some pain. You must remember, some women, when implantation occurs, there may be a little bit of discomfort or pain in the lower part of the abdomen. Some people may even bleed, which we call the implantation bleed. My take on this is that if a woman misses a period, she must just be seen, period. There's no saying, no, I'll wait or I'll whatever, because as we mentioned, things like the ectopic as well, we have to see early.
Earlier you mentioned nausea and vomiting. We're told that it can get quite bad, in fact, for some people, to a point where they get admitted to hospital.
Severe hyperemesis gravidarum or nausea of pregnancy. Yes, it's much worse in patients with twins. But we think there are some people who are very, very sensitive. There are people who even lose weight in the first 12 weeks of pregnancy. Their electrolyte situation becomes quite bad and they become very, very weak. And we have to admit those patients and administer intravenous fluids and stuff. That can be very, very severe.
Right.
Yeah.
But obviously not life-threatening, as it
It can be life-threatening in certain environments. In Johannesburg, I don't see really how we could lose the patient from that. But suppose you are in the rural areas and there's no support in terms of you being admitted and all that, and you can get very, very severely dehydrated and kidney problems start kicking in.
You obviously mentioned, start feeling movements and that sort of thing. But there's a concept called lightning. What is that?
Lightning occurs much later when there's slight descent of the baby.
Right.
That is much later.
That's towards the
Yes, towards the pelvis. The baby has to get into the pelvis. You must remember that for normal birth, the baby has to get inside the pelvic cavity. And then it descends, and then it's going to be an easy normal delivery.
Okay, well, that's a very nice way of, summarizing the whole journey. We're going to go into a bit more detail now in terms of, how to care for that unborn baby. But that after the break. We'll discuss ANC. Please stay with us.
Shield, embracing our members in good health since 1968.
So good, nothing else can replace just your slightest embrace. And if you only would be my own for the rest of my days, I will whisper this phrase, my darling, c'est si bon.
Information-hungry viewers stay with SABC News, as issues on the West are different from issues on the East or here in Johannesburg. So it is not surprising that people who follow the news know that there are two things for sure, that anything can happen, and SABC News will tell you when it does. Because we keep the nation fully informed. We are SABC News.
If we're talking health, then let's talk seriously.
It is my dream that all pregnant women be registered so that we help them through their pregnancy and childbirth and further help them to live long and healthy lives. This is Mom Connect.
Having a healthy baby is a joy. Where can I get info about my pregnancy and baby? The Department of Health will send you important information. How do I do this? You must go to your nearest clinic. If you're pregnant, the nurse will register you for the Mom Connect program. Once you've signed up, you'll get important information straight to your cell phone. You'll get useful information during your pregnancy and after your child is born. This will help to keep you and your baby healthy. You will be able to ask questions. You'll be able to give your opinion on the services received at the clinic. If you're pregnant, don't wait. Go to your clinic and join Mom Connect today. *134*550#. It's free. Mom Connect.
Right, you need to go to your clinic instead, in fact, and that's the clinic in the ANC that I spoke to you about earlier. But before we start talking about antenatal care, let's take AB on the line from Northwest. AB, welcome to Health Talk. AB?
Hello, Papa.
Yes, can you have your question of you, please, quickly?
Yes, sir. I was talking about this, the thing of the baby.
Yes.
Because I'm 54 years. At my age of 54 years, I was 18 years in marriage, and I didn't have children. And I've gone to several GPs, and I've made some checkups, and they've told me now I will never have a child anymore in my life.
And you said you're 54 or 64?
54.
54, okay. All right, AB.
Yes, but,
okay.
But that, yes.
Yeah, all right. That's not.
Can I continue?
Yeah, carry on. But it's just that what you're talking about is a question of infertility, and that is not really what we're talking about today. But thank you very much
doctor,
for. Yeah.
Okay, now, doctor, I want to talk about something that did happen after all.
Okay.
On my age of 54 years, and then that was a miracle that did happen. My
Yes.
wife did have a child. We did have a child on that age, and then that
Right.
was a surprise. And the thing was, one, my wife didn't even know. She didn't even know she was pregnant.
Ah, okay.
That was a lot of surprise. One day at night, and then she was having some trouble pains, and then on that pains, and then the next day, we go to the GP, one of the general, the doctors, and then when he kept the surgery, the doctor just tell us a surprise thing. He tells, now, you know what, your wife is in a labor. And
in
she
labor?
Didn't show.
Okay.
She didn't even show, doctor, that she was pregnant.
All right.
So that was a miracle.
Thank you very much. Very interesting story. Thanks, AB. Dr. Mtsi, I'm going to ask you to comment about that if you know, because it's something that we spoke about. But before that, We welcome from our Pretoria studio Dr. Yogan Pillay. Dr. Yogan Pillay is Deputy DG, HIV, AIDS, TB, Maternal, Child and Women's Health from the National Department of Health. Welcome to Health Talk, Dr. Pillay.
Thank you very much, and
All
thanks
right.
for the opportunity.
All right, I'm going to come back to you in a second, but let's just get a quick response to that caller.
Look, two points that is raised. Having a baby as a man at 54 is not unusual.
Okay.
Missing the fact that the wife is pregnant still doesn't mean she wasn't feeling something.
Yeah.
You know, she ignored it because she thought, I'm married to a 54. As I mentioned at the beginning, there's a whole lot of psychology in pregnancy.
Yeah.
There must have been some changes. Yeah. She may not have been getting her periods, which is a show that she's and the tummy may have been getting bigger, even if she's quite big, and the movements were there.
All right.
But,
Before we
but
started,
you listen to what your mind wants to take into
correct.
action.
Yeah. Okay. So we're talking ANC now, antenatal care, and clearly it's important. One thing we didn't mention is the so-called high-risk pregnancies. Can you just take us through that concept?
Yeah, high-risk pregnancies, I thought we would discuss in the middle of our talk when we actually are starting to see the patients that I'm doing antenatal clinic.
Yeah.
That is where I'm going to identify a high-risk pregnancy and say, okay, you are straightforward, it's your first baby, you are 18 years old, no high blood pressure, nothing, you're going to be attending a normal antenatal clinic. But you are hypertensive and you are diabetic, you have many seizures that have happened, you've had operations, you've had serious other things, then I divide. But first of all, we start at ANC. That is when you become, when the decision is made as who's low or high risk.
All right, let's get a perspective from the Department of Health and cross over to Pretoria and speak to Dr. Pillay. Now, Dr. Pillay, I mean, perhaps let's start off on this whole problem of teenage pregnancies. From the Department of Health's perspective, what is the department doing about this? Or is it a problem in the first place?
No, it is a problem, Selo, and it's a problem, in many parts of the world.
Right.
But in South Africa, we have around 70,000 under 18 young women delivering in our public health institutions annually. And we clearly think that's way too many. And critically, what we need to do and what we are doing is making access to contraception much easier for young people in all of our facilities. We are now working quite hard to make all our clinics youth and adolescent friendly, for example. And that means making the times easier for them to access after school or after university or college, access the clinics to get contraception, and also training the healthcare workers about how to deal with young people and their need for contraception. It's also important, for our communities and families and households to be very supportive of young people and talk about sexuality and sexual health and reproductive health. So this is not just a government issue or government challenge, it's a whole of society issue. And that's one of the reasons we launched the She Conquers campaign. The Deputy President in June last year launched a national campaign focusing on 5 things, one of which is aimed at decreasing teen pregnancies in our country.
Okay, let's talk a little then about antenatal care and access to antenatal care and the programs that are in place. We mentioned earlier we started with the Mom Connect. Just tell us briefly about the government strategy around antenatal care.
I think we want to first start off by saying, Selo, that all pregnancies should be planned, and therefore the importance of sexual and reproductive health and rights as well as access to contraception. But once a couple decides to have a baby, it's very important for them to have access to good quality antenatal care. We've been trying quite hard to get women to come in with their partners as early as possible before 14 weeks. We are currently measuring access to antenatal care before 20 weeks of pregnancy, and only about 60% of mums come in before 20 weeks. So clearly we need to do far more, and shows like yours will help us convince mums and their partners about the importance of early antenatal care. At the moment, it's between 4 and 5 visits that has been the practice in South Africa and globally, the World Health Organization has now looked at new evidence to suggest that we should increase that to 7 or 8 visits during the pregnancy, with the additional 4 visits being in the 3rd trimester of pregnancy, largely to pick up any conditions that might lead and facilitate stillbirths and also pregnancy-related hypertension. So from the 1st of April, we will be implementing additional visits, especially in the 3rd trimester during antenatal care.
But are we measuring the impact of these programs, for instance, Mom Connect and so on, or is it still too early?
No, we are. You will recall that we introduced this, the Minister of Health launched this in August 2014, and to date we have about 1.34 million women registered to get messages weekly during their pregnancy and for the first year of life. And we are seeing fairly significant increases in knowledge about pregnancy and attitude towards pregnancy during the antenatal period, during delivery, and during the postnatal period.
Dr. Mtsi, let's get a perspective on the, obviously on the private sector. What's the picture like?
The picture is slightly different because we've got 2 streams or 2 groups of patients.
Yeah.
There are those who will come late, like he's saying. Our view, in fact, our organization is very strict on the fact that we must have a proper 1st trimester scan for everybody in private practice, because we do have the facilities. Do blood tests to check, because you've got that opportunity right early at about 10 to 13 weeks to see if that baby is normal or not, so that you can give the person options. And then we have to have a 2nd scan at 20 weeks, where we actually are doing now what we call an anomaly scan, where we check for abnormalities again. Unfortunately, some of our patients are being convinced to say, you know what, you don't have to see a gynae until we are 28 weeks. And those are the missed opportunities that we are getting, even in private practice. Patients who are coming very late. And as I said, there are 2 streams. There are those who just walk in and they're 7 weeks pregnant, and then you can start the pregnancy properly.
All right, okay. Yeah, there seems to be quite a lot to discuss, on antenatal care. Perhaps we have a small break and we continue this discussion after the break. After the break, we'll continue about, caring for that unborn baby. Please stay with us.
Shield Medical Scheme doesn't just cover you when you're ill, we'll help you stay well.
Technology is all around us and some can't live without it.
There's also the problem of internet connectivity.
I was speaking to a robot.
It also makes a few governments panic, and therefore they block the internet from time to time.
They just ban the internet, which is the source of my livelihood.
For African technology and social media news, join me, Phumelele Zondi, on Network every Sunday at 7:30 p.m. Central African Time.
Shield Medical Scheme, we don't just talk health, we do health.
Welcome back. If you just joined us, we're talking pregnancy, and with us in our Johannesburg studio, our special guest, Dr. Thandi Mtsi, a specialist obstetrician and gynecologist based in Johannesburg. And next to her, we're joined by Sister Unathi Nqanto, who is a midwife from Charlotte Maxeke Hospital. Welcome to Health Talk, Sister Nqanto. Okay, and of course in our Pretoria studio we have Dr. Yogan Pillay, who's the Deputy DG, HIV, HTB, Maternal, Child and Women's Health. We'll come back to Dr. Pillay just now, but before we start our discussion, we have two tweets that I quickly would like to go over. Tonga Guy says, my wife is expecting and she has been experiencing some harsh pains lately. Is it normal though? Okay. And Soman Gifty says, I've been struggling to fall pregnant and I've been to a gynecologist and done tests, so I'm healthy. What vitamins can I take? Dr. Mtsi?
Okay, I'll start with the last one, which I remember well.
Yeah.
Vitamins to take, look, the most important thing is, why is she not falling pregnant?
Right.
Have all the tests been done? Are the tubes okay?
Yeah.
Is she ovulating? Because the most important thing, if the tubes are okay and she is ovulating and the husband's sperm is normal, chances of pregnancy should increase. Vitamins don't help that much with falling pregnant. You need those three components to be working well. Most of our women tend to go alone for these investigations.
The men must be
and
there
the
as well.
men, 40% of infertility comes from the men. And the pain part, the one that's antenatal and having pain, she needs to be seen. There's a whole lot of questions that we could ask, we don't have time for. Does she have fibroids in her uterus? How old is she? How is the baby lying? What's happening? There are many other things. She needs to be examined by a midwife or gynecologist or doctor, and so that we can see, is her urine okay? Could it be that she's got recurrent urinary tract infections? Or is there something else that we are missing that could be causing the pain?
Okay. Sister Nqanto, you are a midwife from Charlotte Maxeke Hospital. Tell us about your experience with pregnant women in general. When do you get to interact with them?
I normally interact with them at the later stage of pregnancy, but most of them, they come through with preterm labor. Sometimes some of them ruptured membranes at home, and they assume that they're already in labor. So when they come to labor ward, it's normally for assessment and for diagnosing whether they are in labor or not. And I think one of the challenges that we face is that a lot of the women don't know the true signs of labor. So even if she feels a bit of discomfort, she goes straight to the hospital because she doesn't know whether she's in labor or not. Which also goes back to our antenatal care, that we need to educate our women and we need to make sure that they understand the true signs of labor. But with them, normally it's when they come in from the hospital right through until delivery, and sometimes postnatal care. Even, with Charlotte Maxeke, we have a high care area, so sometimes we can spend a lot of time with the patient, even postnatally, because of complications that come about during labor and post-delivery.
So, Dr. Mtsi, clearly there are problems that can be experienced by pregnant women throughout the pregnancy. We touched a little bit on, the ectopic pregnancies and so on. But during antenatal care now, clearly there's messages that need to be sent out, to pregnant women. In fact, not just, through shows like this, the media and everywhere. So what are those things that pregnant women should and shouldn't do throughout pregnancy?
Okay, first of all, the most important message, as Dr. Pillay was saying as well, is to book early. Early means in the first trimester. The pregnancy must be diagnosed and located. That's my thing. Because complications will arise if you come in at 30 weeks, we don't know whether. Because, for instance, with the high blood pressure, with pregnancy-induced hypertension, you find a patient with what you think is a borderline high blood pressure. You don't know what was her original blood pressure. And yet, for me, for instance, a blood pressure of 110/70 is normal. But when I get pregnant, it goes to 130/80. It's high. You get what I mean? So those patients must be seen early. Because the problems can arise in the first trimester where we get miscarriages, all different types of miscarriages. We have to identify patients with recurrent pregnancy loss. You were talking about high-risk pregnancies. There are patients who have what we call an incompetent cervix. That patient has to be is to be identified before 16 weeks, because there are certain things that can help, like a Shirodka or a McDonald's clutch, and that can help. There are patients who later on develop gestational or pregnancy-induced diabetes. So we have to identify them from the antenatal clinic, because we check the urine at every stage with us, with facilities like ultrasound. We check the water around the baby, the growth of the baby. Sudden increase in the weight of the baby, where you suddenly see that a mother was here about 4 weeks ago and she's suddenly coming with a big tummy. Something must be going on in that kind of patient. High blood pressure is still very prevalent. Pregnancy-induced hypertension, or what we call eclampsia, pre-eclampsia or eclampsia, still very common in our population. So those are things that need to be monitored.
Sister Nqanto, what about lifestyle issues? There's always talk about fetal alcohol syndrome and pregnant women taking alcohol, smoking, taking drugs, and so on. What messages do you normally send out there?
I think with pregnant women is that what they need to understand is once you fall pregnant, your lifestyle has to change in one way or another.
Right.
So obviously drinking alcohol during pregnancy is not going to help you. It's going to just, predispose you to certain complications during pregnancy and after pregnancy, and it's also very fatal for the baby. So we always try and educate the patients that to stop alcohol during pregnancy, even postnatally after delivery, and we try and advise them to also not smoke and drug abuse. But the biggest problem, like Dr. Mtsi has said, is that they need to come to the clinic very early, because sometimes they stay, and by the time they come to the clinic, it's usually to come to the hospital because they're in labor or they're in preterm labor, or like there's a certain complication that has happened, like bleeding or placenta abruptio. So we always try and educate them, but it also goes back to antenatal care. They need to book very early, and they need to also read up on pregnancy and the nutrition that they need to follow.
Dr. Mtsi, I'm going to ask you about exercise just now, or physical activity, but let's take Nokolo from Port Elizabeth. I hope I said it right. Nokolo, not Kolo, eh? Nokolo, yes. Yes. Hi, Nokolo. Your question or comment, please?
I am 34 weeks, 3 days pregnant. Yesterday I went to see my gynae, and he said all is well. But then if anything happens, I must just go straight to the labor ward or else call him. I've been seeing him since my first trimester.
Yes.
Did all the tests, all is well, and I'm 37. The 20-week tests were done. They're also normal. But yesterday, after visiting him, with all what he discussed with me, didn't sit well with me. I started feeling like there's something not okay with me, tired, my lower back heavy, like I'm carrying a stone, and my walks did change. That didn't sit well at all. But I'm sitting and resting now. I'm worried.
All right. Let's hear good advice from Dr. Mtsi on that. Dr. Mtsi?
Okay, mid-30s in terms of pregnancy, mid-30s in weeks, the baby tends to have grown quite significantly. There will obviously be discomfort. Now, a lot of people can take that discomfort without any issues. I mean, if she's had an ultrasound, if the gynecologist has examined that baby, checked to make sure that she is well, the discomfort is going to be there. What I personally do with those patients, at 34 weeks, I would assess her again at about 36 weeks. But there is very little that's going to be done about the discomfort and the tiredness.
So no need to panic.
No need to panic, especially if the gynae said everything is normal.
All right. Okay. We don't have time. If we do have time to talk about exercise, we will do that, in the next segment. But for now, time for a quick break. After the break, we now talk about delivery of the baby. Stay with us.
embracing our members in good health since 1968.
Water-wise, water is an essential need. The scarcity of it could lead to loss of many lives, including livestock, plants, and much more. It requires us to use it sparingly and responsibly in times of need, failing which our taps and sanitation will not function. For more on water and weather issues, stay tuned to News Today, every Friday at 4:45 Central African Time. SABC News, making you water-wise.
If we're talking health, then let's talk seriously.
Welcome back. We're talking pregnancy, and in this segment we're going to focus on childbirth. My two special guests in our Johannesburg studio is Dr. Thandi Mtsi, specialist obstetrician and gynecologist, and Sister Unathi Nqanto, midwife from Charlotte Maxeke. And in our Pretoria studio, we have Dr. Yogan Pillay, DDG, HIV/AIDS, TB, Maternal, Child and Women's Health from the National Department of Health. Perhaps let's stay with you, Dr. Pillay. We're going to be talking about, delivery of a baby, and the one concern, obviously, from a public health perspective, is that of maternal mortality around this time. Your comments, please.
So, the minister has a ministerial committee, independent committee that reports to him, and in their latest report, they've been able to show a fairly significant decline in maternal mortality over the past 5 years.
Right.
We now have something like 154 mums dying of every 100,000 deliveries. 5 years ago, that was about double that number.
Mm-hmm.
The major causes, according to the committee, of maternal mortality are the ones I think we've already touched on. One is HIV. The number of deaths related to and associated with HIV have come down very significantly because we are testing and putting mums on antiretrovirals as early as possible, and that's one of the other reasons why mums must come to antenatal care clinics as early as possible. Mm-hmm. The second is what Dr. Mtsi has already mentioned, and that's pregnancy-related hypertension, and that's why we want to have good quality antenatal care as well. And the third is hemorrhage, obstetric hemorrhage. Mm-hmm. And we have interventions on all three areas, and that's one of the reasons we're seeing maternal mortality coming down. Mm-hmm. Of course, we would like it to come down even further, mm-hmm. but we are working quite hard, and we'd really like to thank our frontline health workers, mm-hmm. the doctors and the midwives in particular, mm-hmm. for the care they are providing for mums, and we would like to encourage partners to also play a greater role in supporting pregnant women mm-hmm. during the pregnancy and accompanying them as well to antenatal clinics as well as to the labor ward during the delivery.
All right, great stuff. I want to be starting to talk to Dr. Mtsi and Sister Nqanto around, the modes of delivery. And I want to come back and get your opinion on, obviously, the problem of the ever-increasing rates of cesarean sections as compared to normal vaginal deliveries. But that later. Let's start here in our studio, Dr. Mtsi. There's obviously two ways babies can be delivered, yeah?
Yes, there's two ways that a baby can come out, and one of them is the normal vaginal delivery, or with or without assistance, because you can have what we call a normal vaginal delivery, where you have assisted deliveries, where you can have a vacuum or a forceps delivery.
Right.
So that's still vaginal delivery. The second one is a C-section or cesarean section delivery. Where, those are the main.
Right. So who should have a cesarean section?
The patient who needs a cesarean section.
That's a very good answer. But we have too many cesarean sections than we would like to. That's a fact, isn't it?
There are many facts. I agree. I absolutely agree that there is a significant increase in the number of women who are delivering by cesarean section. Fortunately, it's not just only in private practice, both in private and in government. There's a significant increase. You know, when I started practicing medicine, we were doing very little fetal monitoring, and we're doing things like scalp pH, you know, where you put a needle through the baby's head to see whether this baby is really going through this labor properly. Things have evolved. Electronic monitoring, where we take our mothers, put them in a labor ward, have a belt around the tummy, and monitor that heartbeat, has increased the incidence of cesarean section significantly. Two reasons. You cannot ignore it. Even if it's, you know, it's relatively mild, you're not too sure, because this woman is coming, she's 3 to 4 centimeters dilated. She's already showing signs that there's some unhappiness about the baby. You ignore it, my friend, at your own peril. Because when the chips come down, the parents are going to say, you know, the sister told me that there was something wrong with my heartbeat. So there's a tendency of overreaction because of that. There are other reasons why we're doing cesarean sections. You see, because it's been increasing over the years, this is an increase in cesarean section rate. There are a number of women who already have scissors.
Okay. Let's cross over to Pretoria and get Dr. Pillay's comments. Your final comments on this problem.
So my final comments, you know, before I give my final comments, can I just say about cesarean sections?
Yes.
There's also in the private sector perverse incentives to do it, because, you know, gynecologists can charge more on the medical aid for C-sections than a normal delivery. And there's a significant number, and unfortunately, it's also related to a number of adverse events, you know. So we would like to decrease in the public sector as well the number of C-sections. However, in terms of my closing remarks, one is that pregnancies must be planned, babies must be well cared for from conception through to university or whenever they leave home. And we must really take care of our children and mothers, because you can't have a healthy nation without those two.
Very, very, very true. Your closing remarks, Sister Nqanto?
I will always prefer normal vaginal delivery over cesarean section.
Interesting. Why?
I think it's because post-delivery, a lot of the mothers don't understand the care involved with Caesar, you know. So we have cases where patients are coming back with septic Caesars, and, you know, because they were not taking care of themselves, they were not doing postnatal exercises, Caesar. So with normal vaginal delivery, the baby is delivered, and after 6 hours, if there's no complications, the lady goes home. But obviously, nowadays, we have a lot of complications, like Dr. Mtsi mentioned, that, you know, when we monitor our babies, we pick up a lot of fetal distress. Sometimes there's a lot of uterine activity that contributes to that. So obviously, nowadays, we have a lot of Caesars, but you know, every midwife will tell you that NVD will always be
the better
preferable.
choice.
Yes.
Mothers come to you demanding to have a cesarean section because a friend or a cousin or a sister also had a cesarean section.
It's a very, very difficult one, that one, because you have to make sure that that person has full counseling about the implications, as you mentioned. But I think I will have missed the point if I don't respond to Dr. Pillay. There is no truth in that we get paid more for a Caesar. The hospital gets paid more. I get less. The code of the Caesar is less than the code of a normal delivery.
But the point also made by Sister Nqanto is that it's an operation and it's got complications.
And the normal delivery, I've got a patient right now who's torn up to the rectum because she didn't want to have a Caesar. And now she needs further.
We need an entire show dedicated to this subject.
I agree.
Because I think we need time, but unfortunately we don't have that time. Sister Unathi Nqanto, midwife from Maxeke Hospital, Dr Thandi Mtsi, specialist obstetrician and gynaecologist based in Johannesburg, and in our Pretoria studio, Dr Yogan Pillay, DDG, HIV/AIDS, TB, maternal, child and women's health. Thank you so much to all of you for your contribution. It's been a fascinating discussion.
Thank you.
Bravo.
Thanks for inviting us.
That's all the time we have, unfortunately, for today. And join us again next week on SABC News. Yes, continue sharing those views and comments via our Facebook page, SABC Health Talk, and Twitter. And remember that Health Talk is repeated every Saturday at 2 p.m. and Thursday morning at 5 a.m. I'm Dr. Thandi. Thank you so much for watching. Thank you for your calls. Thank you for your tweets. We couldn't get through to all the tweets, but thank you anyway. Take care.